So we are starting with the next session. Uh, Doctor, yeah.
So, with the permission from the judges, we will start with Dr. Adit Gupta. His IC is going on already. So, he will be talking on presentation and management of post-blepharoplasty complication at a referral center.
A very good afternoon, members of the jury and my dear friends. I'm going to speak about presentation features and managements of complications of blepharoplasty surgery referred to our center. So as the amount of cosmetic surgeries is on the rise, so are the complications going to be on the rise, and this data by ISAPS presents very depictively that how the complications from cosmetic surgeries are on the rise. Eyelid is a very intricate structure, and minute details of the eyelid and even millimeters here and there can cause unparalleled complications which we cannot think about. Upper eyelid blepharoplasty and lower eyelid blepharoplasty are the commonest procedures performed. But why do complications happen? They can be either because of surgeon-related factors or patient-related factors. Now, patient-related factors are beyond our control, but surgeon-related factors certainly can be improved with better training. There are certain predisposing factors like a negative vector of the eyeball where the malar bone lies behind the eyeball is protruded forward, where sometimes untoward complications can happen. Apart from that, excessive removal of skin or cicatrix formation post a transcutaneous blepharoplasty can lead to shape change of the eye. There are various mechanisms by which a post-blepharoplasty eyelid retraction presents with tethering, scar formation, and paralysis of the orbicularis muscle because of cutting leads to all these things. Now, our aim of the study was to analyze the presentation features and managements of unhappy post-blepharoplasty patients with a permanent anatomic or aesthetic complication. It was a retrospective study conducted between June 2018 and December 2023, where standard photographs were documented at each visit. There was a history of prior blepharoplasty surgery, and pre- and post-operative photos were available for comparison with a minimum follow-up of 6 months. The data which was analyzed was whether an upper eyelid or a lower eyelid blepharoplasty was performed, the demographics of the patient, which included sex and age, the surgeon who performed the primary surgery, that is whether it was performed by a general plastic surgeon, an oculoplastic surgeon, or an aesthetic physician, and what management was offered by us to these patients, either conservative or a surgical out. So there were 21 patients in total, of which 3 males, 18 females. The lower eyelid blepharoplasty was the primary surgery in 16 of these patients. Upper eyelid blepharoplasty was in 5. Now, the thing to note here is that general plastic surgeon had performed the primary procedure in 18 of our patients, an oculoplastic surgeon had performed in 2, and an aesthetic physician in 1 patient. From there, we managed around 13 patients conservatively, and 8 required a revision surgery. Now, this is a busy slide which just shows the outcomes of the surgically managed patients at our center. Now, the thing to note is that transcutaneous approach was the commoner approach where patients needed a revision surgery. It was performed by a general plastic surgeon in almost 6 out of the 8 patients, and canthoplasty with canthal procedures were the commonest surgeries performed for revision, and in severe cases, either a SOOF lift or a stenting graft in the form of mucous membrane graft or a dermis fat graft was added along with the canthoplasty. Now, these are 3 depictive case scenarios where in case 1, you see that a 41-year-old gentleman had undergone a prior transcutaneous blepharoplasty. You can see the sagging of the lower eyelid along with fluid festoons and orbicularis rolling. You can also see that there is conjunctival congestion because he had some degree of exposure as well. Now, these patients certainly require a dermis strip or a fat strip graft to give support to the lower eyelid along with an oblique vector and a vertical vector lift of the eyelid tissue. This young lady had undergone a transconjunctival blepharoplasty with a general plastic surgeon, and you can see the asymmetric lower eyelid retraction along with cicatricial entropion, which is causing congestion of the ocular surface. Now, this lady needed release of the cicatrix or the scar tissue as seen here, along with which the inferior oblique muscle, which was also present in the tether, was released, and a dermis strip graft was placed in the inferior fornix, which then got conjunctivalized later on, and you can see beautiful outcomes at 6 months and 1 year following the surgery, apart from the bulkiness of the lower eyelid. What happens when too much skin is removed? When excessive anterior lamella is removed, you can see that it can lead to an ectropion along with transient paralysis of the orbicularis muscle. So the key in these cases is that you have to buy time, and the patient has to undergo scar modulation as was offered in this patient. You can see hyaluronic acid gel is being injected, and you can buy around 3 to 6 months before you dare to retouch this patient or do a corrective procedure. So to conclude, the margin for error in cosmetic eyelid surgeries is minimal. Majority of the complications can be managed conservatively, while few need revision surgeries, which is best performed by an oculoplastic surgeon. Scar modulation and fillers should be used as the first line of management even before we prepare the patient for surgery. And most important part is you need to counsel and handhold these patients and take them through their rehabilitative journey together. But last but not the least, it is best to identify problem patients preoperatively with a history of prior blepharoplasty, patients having a negative vector or body dysmorphic disorder. Thank you.
Does anybody have a quick question for the speaker? So, Adit, great job. Glad
Thank
you're
you.
analyzing your results. Are you able to comment upon the only two cases were done by oculoplastic surgeon, majority by a non-oculoplastic surgeon?
Yes.
There's no statistical significance here, but are you able to say the factors that predispose to undercorrection or scar from an oculoplastic surgeon done procedure versus a non-oculoplastic done procedure? Just a trend in any forms.
Yeah. So one thing which I have noted is when a general plastic surgeon does the surgery, it's mostly transcutaneous. So, and I have seen that they remove too much of the skin because they don't have an idea that the eyelid is such a delicate tissue, and even 1 millimeter here and there can cause a retraction. Secondly, the patient which was done by a general plastic surgeon, the cautery which they use sometimes is an electro cautery which they use for general procedures as well. So the heat which is generated is certainly more than the radio frequency cauteries that we use, which could lead to the cicatrix or the scar formation. Oculoplastic surgeons, it was mostly lateral canthal dystopia where skin was removed, but the same pathophysiology stays even with an oculoplastic surgeon. The pathophysiology stays the same.
Thank you.
So how was this case was decided that this will be done by oculoplastic surgeon, this will be by general surgeon? Just means because anything sometimes it happens.
Yes.
That I am not confident that this will be done good in better hands. So like not like that or something like that, something objectivity or some only subjective.
No, so these patients were the surgery was already done by a general plastic surgeon and by an oculoplastic surgeon, and these were referred patients who came to us. So there was no randomization in these cases.
Okay.
But means the main broader aspect here is that the surgery should be performed by an oculoplastic surgeon and should be referred to an oculoplastic surgeon.
Thank you.
Thank you, sir.
None of the general plastic surgeons use their transconjunctival movement. In many that people pick up, no?
Yes. So nowadays plastic surgeons have also started doing transconjunctival surgery.
In your
Yeah.
group, none of them
They were. So the entropion which we saw along with the retraction was done by a general plastic surgeon.
transconjunctival.
Yes. Thank you so much.
So we can move to the next speaker, Dr. Kaushambi.
Good afternoon, everyone. I'll present a paper on ocular morbidity and quality of life in patients with thyroid dysfunction. Thyroid eye disease, also known as Graves' ophthalmopathy or Graves' orbitopathy, is an autoimmune disorder affecting retrobulbar tissue characterized by inflammation of orbital and periocular fibroadipose tissues. It is the primary extrathyroidal presentation of thyroid dysfunction which frequently results in disfigurement and lowers the quality of life for those who experience it, and hence has a significant direct and indirect financial implications in healthcare systems. Our aim is to study the pattern and severity of ocular manifestations and its relationship with quality of life in thyroid dysfunction. These are our objectives. As was a cross-sectional observational study over a period of 18 months with the sample size of 77, we included all consenting adult patients attending IOPD and diagnosed with thyroid dysfunctions. We excluded the patients who refused informed consent, had history of ocular trauma, had proptosis due to any other cause, and malignant thyroid disease. The study protocol and patient assessment consisted of self-administered questionnaire which had these demographic data. The clinical assessment was based on Bartley and Godman criteria. Objective evaluation was done using VISA score, and a detailed ocular examination was done. Disease severity was evaluated through CAS score and UGOGO classification. Quality of life was assessed using Graves' ophthalmopathy quality of life questionnaire, which covered visual functioning and appearance, and we translated the questionnaire into Hindi for patient completion. These are my results. Most number of patients belong to the age group of 41 to 50 years. Male to female ratio was found around 1:1.5. Exposure to smoking was seen in 22.10% of the cases. Majority of the patients were hyperthyroid, 51.90%, which was followed by hypothyroid, 33.80%, and euthyroid, 14.30%. The mean VISA score of patients was 10.92 plus minus 4.33. Maximum patients had a CAS score of 2 and least number of subjects had a CAS score of 7. Majority, that is 59.70% of the cases had inactive disease, that is absence of soft tissue changes. Majority of the cases had mild disease, that was 55.80%, moderate to severe disease, that is 28.6%, and sight-threatening disease, that was 15.60%. Majority of the patients in this study presented with the chief complaint of staring look. Other presenting complaints were retrobulbar pain, redness of eyes, watering, diplopia, and diminution of vision. On examination, the most common finding was lid retraction, followed by proptosis, dry eyes, extraocular movement restriction, defective vision, diplopia, leg of thalamus, disc changes, defective color vision, corneal involvement, and RAPD. The mean visual acuity subset was 25.37 plus minus 31.46, and appearance subset was 23.41 plus minus 23.64. Mean total quality of life was 24.39 plus minus 21.87 with a maximum QOL value of 85 and minimum value of 0. Sight-threatening TD had very poor quality of life compared to moderate severe TD and mild TD. In present study, we found that there was a significant correlation of age with VISA score, CAS score, and total quality of life. The female patients had higher visual functioning but lower appearance scores, possibly indicating differing priorities in quality of life aspects. Younger patients had low appearance scores, suggesting vulnerability to negative emotional effects of Graves' ophthalmopathy. To summarize, there are no significant gender difference in TED in our studies, unlike Caucasian studies. Age at presentation aligns with global trends. Higher proportion of hypothyroid patients had mild disease. Severe TED was prevalent among lower socioeconomic groups. Smoking significantly worsened TED severity. Systemic diseases and family history of thyroid dysfunction influenced TED severity. Isolated lower eyelid retraction, common in Southeast Asian studies, may aid in TED diagnosis. TED substantially impacts quality of life. The clinical implications emphasize the importance of proactive ophthalmic care. The GeoQL survey comes in as a simple and valuable tool to evaluate the severity, and the grading and classification systems like VISA, UGOGO, CAS, and NOSPECS have proven to be essential tool for the better understanding and provide excellent patient care to patients suffering from the Graves' disease. Thank you.
Any questions? Any questions for the audience for the speaker? If not, I will ask you two questions. I know there are different quality of life scores and tables, right? How did you choose a GeoQL?
So basically we wanted a quality of life which impacted male, female, and children. So GeoQL has two things: one the appearance scale and visual scale. So it has 8 things in the visual scale and 8 things in the appearance scale. So based on that, the 16 criteria, it seemed preferable. So that is why we
Right. And the second, 2 other points quickly. You mentioned 30% of patients had reduced visual acuity.
Yes, sir.
That's an alarmingly high number.
Sir,
What proportion of them was neuropathy versus keratopathy?
Sir, most of the patients that came were from lower socioeconomic strata. So they're not well aware that they have any kind of disease. So mostly they represented when the disease was already in the moderate form. So that
No,
is
what is the etiology of the vision loss in the 30% of patients that you had? Was it optic neuropathy or exposure keratopathy?
Sir, mostly it was exposure keratopathy because of the superior limbal keratoconjunctivitis.
Right.
And sir, in the severe cases there was orbital compression, so optic neuropathy.
What proportion?
Pardon?
What proportion of patients of the 30% was compressive neuropathy?
Sir, hardly 8 to 9%. Sir.
Okay. Hardly. 8 to 9% is 1 in 10.
Yes, sir.
Not 1 in 11. Yeah. Thank you very much.
Okay, thank you, sir.
Having Dr. Isha Agrawal, so you can start.
A very good afternoon to the members of the jury and to the respected audience. So I'm Dr. Isha Agarwala and my topic is a reverse algorithm for Muller's muscle resection surgery for ptosis correction. I have no financial interest to disclose. The aim of this study was to evaluate the surgical outcome of molar muscle conjunctival resection (MMCR) surgery performed with a reverse formula. But what exactly is reverse and what is MMCR? So to talk about what exactly is reverse, the molars muscle is a smooth muscle that is sympathetically innervated and elevates the eyelid by 2 to 3 mm. Conventionally, a phenylephrine test is used to stimulate the molars muscle and to evaluate the outcome of performing a MMCR surgery. But in this, we are doing a MMCR procedure without performing the PE test in mild ptosis patient with a good LPS activity, providing enough evidence that phenylephrine test is not entirely necessary to perform a MMCR surgery. So is reverse good? Well, we'll see. Because reversing in size is amazing and reversing to old music tracks is also good. So we'll see about the surgery. To understand what exactly is MMCR, we first need to understand how does the molars muscle help in ptosis correction. To look into this, we first have to know the molars muscle anatomy. So molars muscle is located in the posterior part of the eyelid. As we see in this image, the yellow portion in the diagram shows the LPS muscle. The purple portion shows the tarsus and the red portion shows the molars muscle. So basically it is placed in the posterior part of the eyelid. So in ptosis, conventionally we have two diverging schools of thoughts, which is the anterior approach and the posterior approach. In this we are going to perform the posterior approach, and in this study we had a total of 14 eyes with mild ptosis without performing the 2.5% phenylephrine test with good LPS activity more than 10 mm. Mild ptosis patients of 1 to 2 mm ptosis and LPS more than 10 mm were enrolled. The patients were recruited from Oculoplastic Surgery Department of Drishti Netralaya and Vivekanand Netralaya. Prior history of oculoorbital, eyelid or eyebrow surgery, trauma, any systemic disease were excluded. So how much tissue to excise? The amount of excision was 9 mm when the ptosis was 1 mm and 10 mm was resected when the ptosis was 1.5 to 2 mm. In the surgical technique, we first use a Dimas retractor to evert the eyelid and the posterior surface. A predetermined amount of molars muscle and conjunctiva was measured and marking was done. From the superior border of the tarsus, a Putterman's clamp was placed and the sutures were passed and the tissue was resected. So coming to the results, in this study we had 14 eyes of 10 participants, out of which 6 were females and 4 were males. The mean standard deviation of age was 35 plus minus 15 years. 7 patients had aponeurotic ptosis, 3 patients had a congenital ptosis. The mean preoperative LPS function was 12 plus minus 2.6 mm. The mean conjunctiva resected was 9.46. So in this, the amount of tissue resected, 9 mm was in 4 patients, 10 mm was resected in 6 patients. The mean MRD1 was statistically significant in the first, third and 4 months post-operatively. Post-operative symmetry where MRD1 within the 0.5 mm of the fellow eye was achieved in 9 patients. No overcorrection was seen. So this was our first patient where the patient had mild ptosis, both the eyes, LPS activity was 12 mm. In post-operative period, good correction was obtained. In the second patient, mild ptosis in the right eye, LPS activity was good, good correction was obtained. In the third patient, we had a mild ptosis in the left eye. We did a MMCR 9 mm and good correction, contour maintained. The last patient was a congenital ptosis. So coming to the end, MMCR is a less invasive procedure causing no damage to the orbital septum and the fat pads, especially in patients with deep superior sulcus. The posterior approach provides less tissue dissection, absence of cutaneous scar and shorter operative time. So for resection, we used a formula similar to the study in Perry et al. In Ophthalmic Plastic and Reconstructive Surgery Journal for correction of ptosis. 9 mm was the baseline amount resected, which was added or subtracted according to the MRD. So the mechanism that we postulated here was vertical posterior lamellar shortening causes the secondary contractile cicatrization of the wound and advancement of the molar muscle LPS complex to the tarsus. We excluded LPS less than 10 mm because with weakened aponeurosis, if the weak fibers were transmitted to the tarsal plate, no force or strength would be transmitted, hence no elevation. The disadvantages were we excluded the dry eye patients, patients with ocular surgery disorders. Resurgery is difficult to predict and perform. Thus, I would like to conclude by saying MMCR is an alternative procedure in patients with mild ptosis and good LPS. Procedure is less invasive with low complication and reoperation rate. Thank you.
Thank you, Dr. Isha. Any question?
Why did you
Good afternoon, everyone. So my paper is Incidence, Cumulative Mortality and Factors Affecting the Outcome of COVID-19 Associated Mucormycosis from Western India. Okay. So this is the table of contents. So coming to the research background, the COVID-19 pandemic has led to devastation across the world with multiple waves of infections. And in addition to the viral infection itself, there has been an increased number of opportunistic infections, including fungal infections. Ours is a tertiary care multi-speciality government hospital in Maharashtra. And our hospital had catered to more than 50,000 patients with moderate to severe COVID-19 infections. So we observed an outbreak of COVID-19 associated mucormycosis in March 2021, and we reported the underlying predispositions, morbidity, and mortality outcomes. So though some published studies reported outcomes, none of them used survival analysis to report mortality and morbidity. To the best of our knowledge, there were no studies addressing the cumulative mortality rates. So the outcomes from a single multidisciplinary center carry merit in terms of more thorough documentation. So coming to the methodology, this was a retrospective study at a tertiary care hospital. Informed consent was obtained. Case records of COVID-19 patients with a diagnosis of CAM were identified. Patients with minimum follow-up of 30 days were included. And the patients were classified into proven, probable, and possible CAM. Ophthalmic manifestations were recorded, and the basic demographics and complete diabetic profile was recorded. A potassium hydroxide mount was prepared. Saburod's dextrose agar was used to culture the fundus. A CT or MRI scan was ordered. Time interval between COVID-19 recovery and the onset of CAM was recorded. History of steroids was retrieved. History of requiring supplemental oxygen as well as non-invasive ventilation were all recorded. All the patients were advised endoscopic sinus debridement with lavage. The patients were administered IV amphotericin B when it was available in the wards. The time for adverse outcome was defined as the interval between the time of admission and either death or orbital exenteration. Orbital exenteration was planned for patients with advanced orbital disease characterized by the adverse ophthalmic manifestations. Outcome was recorded as death, exenteration, or recovery. The statistical analysis was done, and the survival analysis was performed using adverse outcomes in the censoring variable, and Kaplan-Meier curves were plotted. Then coming to observations, our hospital admitted 4,910 patients with moderate to severe COVID-19 and saw 67 patients with CAM. Of these, 28 were proven CAM, 5 were probable, and remaining 34 were possible CAM. The mean age was around 55 years. One patient had bilateral disease. Majority of them were diabetic. 9 patients were diagnosed with diabetes, and the CAM developed approximately 15 days after recovery of COVID-19. This was a comparison of the demographics and clinical characteristics. These were the factors associated with adverse outcome of either death or exenteration. These are some of the clinical pictures showing ptosis, then nasal eschar with facial palsy, palatal eschar, orbital eschar, ptosis with ophthalmoplegia with facial palsy. 84% patients had received steroids for COVID-19 management. Prolonged oxygen supplementation was needed by 52 patients. All patients had orbital involvement. 3 patients had an intracranial extension. Pansinusitis was the commonest involvement. Of the 67 patients, 26 experienced an adverse outcome, with 23 having died and 3 underwent orbital exenteration. Patients who had adverse outcomes were all diabetic. Patients with adverse outcome presented with much worse disease. A multivariable Cox proportional hazard analysis with the best fit model showed that history of receiving assisted ventilation led to nearly 7-fold increase. And in the same model, the patients who received amphotericin B had 67% reduced risk of outcome. Kaplan-Meier survival estimate was shown like this. Now, in this retrospective study involving 67 patients, we found that almost all patients had underlying predisposing factor, uncontrolled diabetes, and high rate of ketoacidosis. Prior use of systemic steroids and need for supplemental oxygen were the other strong predisposition factors. The onset of CAM was about 15 days after recovery from COVID-19 infections. Cumulative probability of mortality was 24% at day 8, and it was increased to 38% at day 20. We reported a relatively low incidence of orbital exenteration. And Sen et al. From the largest series reported 17% exenterations. The use of prolonged oxygen has been postulated to be a risk factor for CAM. However, 22% of these cases did not receive any supplemental oxygen. Similar results were reported by Sen et al. Drawbacks of a study are its retrospective nature and the lack of documentation of the duration of steroid use. The advantages of our study are relatively large number of cases of these very rare disease occurring in the form of an outbreak, allowing us to understand the disease behavior, mortality, and morbidity rates. To the best of our knowledge, this is the first study providing a survival analysis, cumulative mortality, and hazards ratios for factors predicting death or exentation in the CAM. The mortality indicators we found, that is the need of assisted ventilation in the past and the presence of severe orbital manifestations, can help physicians triage patients for emergency procedures and administrative systemic antifungals. So to conclude, we report the underlying risk factors, mortality and morbidity outcomes from an outbreak of CAM infections from a multi-speciality hospital in India. This is the first study reporting the cumulative survival rates. These are my references, and thank you very much.
Statistical data, so that in future, suppose if we are managing these cases, so we can limit the uses of steroid and that way.
Yes, we had documented that majority of our patients had received steroids in the form of IV methylprednisolone and followed by dexamethasone. So it was a major risk factor in our series. Okay.
Next, we have Dr. Komal.
So very good afternoon. I'm Dr. Komal, and I'm going to present my study over the integrated eyelid myomectomy to treat the patients with blepharospasm and apraxia of lid opening. So as we all know, apraxia of lid opening is a non-paralytic inability which affects the quality of life, and the available treatment options are ineffective and have a high risk of complications. So the debate is always in between which alternative treatment is important. So most of the researcher has researched over the protractors of the eyelid, and many of the studier has also accepted results with the upper lid myomectomy. However, 50% of the patients eventually require lower lid myomectomy. So considering this, the aim of the study was to assess the effectiveness of upper and lower lid myomectomy in relieving the blepharospasm. Primary objective was to assess the improvement in blepharospasm using the functional disability score, assess the dry eye photophobia, and the secondary objective was to see the impact of the treatment on patient functioning using the disability questionnaire. So these were the study parameters. We included the patients who were refractory to botulinum toxin with no prior eyelid surgery, and we excluded the patients with other tonic disorders and patients with other eyelid abnormalities. Talking about the surgical technique, so we concentrated over the protractor of the eyelid, including the orbicularis oculi, the corrugator supercilia, the depressor supercilia, and the procerus, and its described extent. Coming to the surgical video. So we usually tried the blepharoplasty incision followed by excision of the orbicularis oculi, where the plane of dissection was just below the skin, where we concentrated more over the protractor like the procerus and the depressor corrugator. Here, while doing so, the important structure like superior ophthalmic vein has to be identified and saved. So the similar procedure was done in the lower eyelid as well. So altogether 24 eyelids or 12 patients were included, where all underwent upper and lower lid myomectomy. Additional few patients, we did an additional procedure of levator aponeurosis resection along with the canthal plication as well. So these were the postoperative results. At the end of 1 month, almost 17% patient responded that their ALO symptoms was relieved, with 33% improvement in the dry eye symptoms, where at the end of 1 year, almost all patients were relieved of ALO and 83% had improved dry eye symptoms. Only 2 patients required botulinum toxin injection at the end of 1 year, and mainly to the lower eyelid, however with the minimal doses. We also found statistically important results at the end of 6 months and at the end of 1 year. There was also improvement in the photophobia and dry eye at the end of 1 month and 6 months. Along with the minor and manageable complications, the marked forehead numbness was the important one, so all the patients should be counseled before the surgery. Coming to the discussion part, so the injection botulinum toxin
was effective in relieving the blepharospasm but not successful in treating the dry eye symptoms. So when we talk about myectomy versus dry eye versus blepharospasm, we found that a very high incidence of dry eye in our study. Nevertheless, almost 80% of the patients experience improvement in the dry eye after the surgery. And the most probable reason to that could be the reduced protractor contraction that acts over the canaliculi and induces a decreased pump function during blinking and hence increase the tear retention, or maybe the result of correction of the eyelid malpositions. But being a pilot study with limited cases, we need to find out the exact outcomes and explanation in the terms of dry eye. Talking about the surgical aspects, we advise to leave a small amount of marginal pre-tarsal orbicularis in order to avoid any ectropion or tearing after the surgery. So one may ask, what is the major or the maximum limit till the orbicularis can be removed? So the fact is that it is virtually impossible to remove all the orbicularis, and the surgeon have to allow several hours to expurgate all the accessible protractors, and the results are directly related to the completeness with which the orbicularis is removed. So to conclude, integrated eyelid myectomy has been shown to be a viable treatment options in the refractory cases of blepharospasm with ALO, with an added advantage of comparatively definitive, cost-effective and bilateral procedure. We do not believe that this or any other procedure cures the ALO associated with blepharospasm. Since ALO with associated blepharospasm being a functional condition, surgery is indicated at the rehabilitating the patient and allowing them to live a better quality of life. Thank you.
You mentioned certain more additional procedures apart from myectomy. Would you please show that slide? How does it affect the final outcome? Is there any subgroup analysis?
Yes, ma'am. So there are three patients where we have done LPS reinsertion because there was LPS aponeurosis, disinsertion, and canthal plication also was done. So it might affect the result of the study.
Did you analyze it in the groups
No,
where you did the additional procedure? Is there
no,
how
though it
it's
was a
going to affect
pilot
it?
study, so we not that done this, but yeah, could be.
Yeah, great study, Komal. So you showed in the outcome part that at 1 month, only 16% the symptom was reduced. However, over a period of 1 year, it was 100% of the patients who said that they were free of their symptoms. So what is the most possible cause for the same?
So as I already said, we targeted most of the protractors, like including the orbicularis and the procerus and all. That could be the reason. But yeah, the delayed positive results, that we have to study more.
Yeah.
Next we have Dr. Sandeep Kumar Sahu. We're talking on periorbital arteriovenous malformation.
Okay, thank you. Good afternoon, you all. This is a case report. Periorbital arteriovenous malformation with a rhinosporosis extending into oropharynx. So this is case of 48-year-old businessman, chief complaint of painless swelling near right eye, lower lid for past 1 year. Swelling was insidious in onset and gradually progressive and was associated with watering from the right eye. It was painless and was not associated with diminution of vision or any other ocular complaints. On examination, it is a soft, non-tender, non-translucent, hypopigmented mass with dilated blood vessels seen near lower eyelids, which was extending from the medial canthus over the lacrimal area to upper cheek, and no trial pulsation was felt. The size of the lesions did not increase with pulse of maneuver, and mucoperineal discharge was there, and it is a partial patent with hard stop. And the CT he was carried with shows 32 into 19 into 24 millimeter heterointense lesions with linear serpiginous vascular structure within it, and seen involving the right lower lid, involving likely to be a provisional diagnosis of a low flow venous malformations. So we plan for a excision biopsy, but when it's a incision given, it's a profuse bleeding. So we control the bleeding and plan for and stop the dissections and plan for a evaluation with imaging and any scope for guided use of sclerosing agents. So on CCT showing soft tissue with a bunch of vessels at medial canthus of right orbit. Lesion is extending to along with right nasal cavities and extending up to the uvula. And there is a 3D multiphasic images of CT angiography showing a vascular malformation involving nasal cavity. So there is a sclerosing agent will be washed out if you thought about that, and we sought for a ENT consultation. On endoscopy, it was found to have a mass of rhinosporidosis in interior meatus extending to the nasopharynx and going to the lacrimal duct system. So with a diagnosis of with imaging with AVM and rhinosporidosis ENT endoscopy, we plan for both open and endoscopic excision and biopsy for it. So on histopathology, it have two distinct lesions. One is superficial, one is a deep one. And superficial lesions show a large thick-walled sporangia with endospores in subepithelial and in the epithelial layer. So it's rhinosporidosis, and deep one with dilated congested vascular channels with variable size vessels, which showing a haphazard arrangement of the smooth muscles and suggestive of arteriovenous malformation. This is another view of that, and also endoscoping tissues also show rhinosporidosis and arteriovenous malformation. So periorbital rhinosporidosis can coexist with arteriovenous malformations, and rare multiphase CT angiograph can help in management before final diagnosis with histopathology. Valsalva test may be masked due to superficial lesion. And concluding with managing orbital AVM with rhinosporidosis poses a significant challenge and require a multidisciplinary approach and careful preoperative planning. And it is paramount to consider unusual differential diagnosis in cases where typical clinical and imaging features are inconsistent, and increase awareness for these unusual presentation can aid in prompt and appropriate treatment, preventing potential complication and improving patient outcome. Thank you for listening.
Thank you. So was this finally rhinosporidiosis, or was this a vascular malformation? So was this rhinosporidiosis, or was this a vascular malformation? What was the final diagnosis?
Both are coexist with a deeper lesion is a arteriovenous malformation and rhinosporidosis as a histopathologist.
What is the mechanism according to you?
Mechanism. This is a coexist. It's not any mechanism to have a correlate with rhinosporidosis and arteriovenous malformation, but it's a real condition. It can occur both the lesions in same site.
Right, because your presumptive diagnosis was a low flow malformation.
Initially we diagnosed it is a low flow vascular malformation, but during the surgery, the bleeding, so it is actually not a low flow. Low flow means that is capillary, lymphatic, and this venous one, and it's a high flow, means arteriovenous malformation. So during our surgery, so we thought it's something.
During a surgery, the nature of bleeding. What is the nature of bleeding?
Nature jet type. When we nick it, the as it is an arterial one, okay, it will not a oozing one. It will a jet type of.
So it is just a vascular lesion.
So it is a arteriovenous malformation. So but it is masked in Valsalva and band test. That is another thing. Usually in a vascular means arteriovenous malformations, it will be increased with your Valsalva. Also there may be a proptosis if it is a retrobulbar extension is there. But here in my case, there is it is negative.
Thank you.
Mix of rhinosporidosis and AVM has been previously reported in literature.
No, it's as I searched in PubMed, there is no such report before. Both coexist.
Akhtar, she is talking on marble in the orbit, unusual path.
Good afternoon, everyone. Today I'm presenting a case of a rather interesting case where we found marble in the orbit by an unusual path. A patient presented to us, 12-year-old boy with an alleged history of injury to the left side of his face by a homemade firecracker, which in local language is called naal, 2 days prior. He had sudden painful loss of vision in his left eye following the injury, along with an episode of loss of consciousness and 5 episodes of vomiting. On examination, the right eye was found to be absolutely normal with a vision of plane 6/6, In the left eye, there was diffuse slit edema, ecchymosis was present, along with complete ptosis. This image might be a tad misleading because in this, the thumb of the examiner is being used to lift the lid for a better view. There was sutured laceration present, roughly 2 cm below the left lower lid. The eyeball was displaced inferiorly, ocular movements were restricted, the conjunctiva was congested with a clear cornea, pupil was dilated and non-reacting, there was no perception of light, and fundus could not be visualized due to hyphema present. First, we sent all the blood investigations, which came back normal. Then, the patient was sent for imaging. The CT scan showed the axial view with an intraconal foreign body in the left retrobulbar space. Further cuts showed fracture of anterior wall of left maxillary sinus with the left orbital rim. Then we did a 3D reconstruction of the face, which beautifully showed a spherical foreign body in the left orbit. The axial view, sagittal, and the coronal view also showed the foreign body with orbital floor fracture and hemo-maxillary sinus. Then, the patient was given a 3-day course of IV steroids, which resulted in reduction in periorbital swelling and ecchymosis. The patient was taken for a surgical exploration under GA through an inferior transconjunctival orbitotomy. Retrobulbar space was entered laterally and a greenish foreign body was visualized, which was extracted, and it was found to be a marble measuring approximately a size of 1.5 centimeter. There was a breach in the orbital floor, however no prolapse of orbital contents in the maxillary sinus was noticed. The inferior rectus was completely tethered and therefore no attempts was made to repair it. The child made an uneventful recovery with significant improvement in pain and ecchymosis. These are the photographs of post-operative day 3 and they showed significant reduction in inflammation. The extraocular movements recovered in all but the down gaze. However, no visual improvement was noted due to CRAO. This is the image of the patient 1 month post-op. The wound site was healthy with no signs of inflammation, but the eye was still in ptosis with no gain in vision. Sadly, the patient didn't turn up for follow-up after this. Coming to a brief discussion. Retrobulbar foreign bodies are rare but potentially sight-threatening ophthalmic emergencies. They can be caused by a variety of mechanisms, including penetrating trauma, RTAs, or occupational hazards. Clinical picture can vary depending on size, composition, and location of the foreign body. Early diagnosis is essential, and a thorough ophthalmic examination, including imaging studies, is critical in detecting its presence and location. If left untreated, it can lead to optic nerve damage, permanent vision loss, or even life-threatening complications, such as orbital cellulitis or cavernous sinus thrombosis. Management includes prompt removal and appropriate management of associated injuries. Surgical intervention may be required, and the method of removal depends on the size, location, and nature of the foreign body. So, in conclusion, this case highlights an unusual orbital foreign body following an unusual injury via an unusual path. It emphasizes the need for maintaining high index of suspicion in patients presenting with ocular trauma. A timely intervention can prevent significant morbidities associated with these kinds of injuries. Thank you.
What was the route of entry of the foreign body? From?
Ma'am, through the maxillary sinus.
Through the maxillary, from which side? Inside or from that skin area?
The laceration which was seen entered through that 2 centimeter below the left.
Then it went into the retrobulbar space.
So what do you plan to do for the residual hypotropia and ptosis?
Ma'am, for ptosis, we can do any of the ptosis correction surgeries with the patient, but the main concern for the patient was loss of vision. He was not concerned for ptosis that much. So that was maybe also the reason we lost the patient to follow-up.
So very well presented. Aligarh, I usually expect a socket case. In a way, it's a socket case, right? So preoperatively, you didn't do an X-ray. You did a CT scan,
yes,
which is great. If you did not have any history, are you able to identify the material based on CT scan?
So yes, sir, by the density of the material, we will be able to identify what kind of material it is.
How will you measure density of the material?
So by it's hyperdense on the CT scan.
Compared to?
So compared to the bone, compared to the soft tissue surrounding it.
You say, anybody? Ushak, you want to teach us?
Hounsfield units.
Did you measure the Hounsfield units for this foreign body?
No, sir, I didn't measure the Hounsfield.
Right, so that's a very practical tip that you want to say, because sometimes patients don't come with the history. And that's a very useful tool to figure out what kind of foreign body it is. Of course, when you're going to take it out, that's fine, but a lot of times we can't take it out. And you want to know ahead of time, so well done. Thank you.
Thank you, sir.
Good afternoon, everyone. I am Dr. Chavi Gupta, and I'll be presenting a novel and inexpensive training model for teaching basic steps of oculoplastic surgery. So we all know that ophthalmic surgical training has a steep learning curve, which requires large numbers to have a stepwise surgical competence. A model of see one, do one, teach one. Here the patient safety is at risk with ethical concerns. And we do have wet lab and simulators, but not enough for the oculoplasty surgeries. And there are certain surgeries that the residents and the general ophthalmologist should know. So our aim of the study was to assess the utility of pighead as a potential surgical training model for surgically naive trainees for practicing basic steps of common oculoplasty procedures like upper lid entropion, evisceration plus minus implant, and lid margin tear repair. The methodology involved procurement of the pig head from the ablator, establishment of surgical workstations in the already present wet lab, didactic lectures and video demonstration of the surgical steps to the trainees, and step-by-step guidance and supervision by expert oculoplasty surgeons to the trainees. All the three surgeries were divided into cardinal steps like traction suture, tarsoconjunctival incision, dissection, and mattress everting sutures. And this was the result. And similarly, EVIS implant was divided into the three cardinal steps. And similarly, the steps of lid margin were divided into various cardinal steps. So for the assessment of the performance of the trainees, we had a subjective scale, Likert scale-based questionnaire. One was for the mentors to evaluate the trainees whether they were able to perform the step, had difficulty in performing, or could not perform the step. And for the trainees to assess the tissue feel, improvement in skill, and also their understanding of the surgical steps. Also for the objective assessment, we had developed a surgical competency-based rubric for the upper lid tarsal fracture, which was vetted by 3 experts and validated by a cohort of fellows. It included 5 key steps of surgery and the global indices. It was based on the modified Dreyfus model and had a numerical tracking system to reduce the errors, descriptive narratives, and then scores of the performances were calculated. And this also led to translation to OT, where 3 of the participants performed on real patients, and the same rubric was used to calculate their scores. So we had 18 participants, which were residents and comprehensive surgeons, and 84.6 had never observed or assisted these surgeries. And these were the percentages of surgeries that, steps that they were able to perform, and the responses made by the trainees. And this was for the evisceration implant. And this is for the lid tear repair. So as we can see, the median score in the validation process was 4, and median score participants in the workshop was 3, and the median score achieved by the participants in the OT was 4. And also it helped with managing of the hemostasis, with patient cooperation, and also overcoming the apprehension. 100% of the participants felt that practice on pig head made the surgeries easier, and 92.3 participants felt that understanding and skill and confidence of the surgical steps improved with this. An ideal model for surgical training should simulate normal anatomy, should be readily available, inexpensive, and involve low risk of disease transmission. Pig model has been used previously for the mentioned surgeries and also for glaucoma and cataract surgeries. Advantages are it is available and affordable, has similarities to humans, and has a larger size. And 100% participants felt similarity in the gross anatomy, and 84.6 for the tissue maneuvering and the texture similarity. The differences are that the upper tarsus is smaller compared to the human, but the skin and the tarsus is thicker, so we can use larger free-cutting needles. The subcutaneous tissue is more fatty. There is a third eyelid that is present, and also presence of the retractor bulbi muscle. So, in conclusion, porcine model is affordable, usable, and achievable in a resource-constrained training environment, recommended for early training, and can improve the anatomical understanding, clinical judgment, and surgical efficiency in trainees and beginners. And the rubric that is being developed can have future application for assessing the performance of the trainees. Thank you. These are my references.
You mentioned 9 global indices for objective assessment. What
Yes.
are those?
So, ma'am, there are 9, but we could incorporate 4 into our OSCAR. That was understanding the anatomy, using of knowledge of the instruments, maintaining the hemostasis, but this was not applicable to the pig model, and also mounting of the suture, mounting of the needle and holding of the needle. So these are the 4 global indices.
Just have a practical question. Did you have any religious constraints in doing the study or the workshop?
So not at the time of workshop, but because these live the animals were not harmed particularly for this workshops. These are the already slaughtered animals that are procured from the abattoir. But in the workshop, we did not have any such religious
Barriers?
No, sir.
From
no.
the participants' point of view?
No, sir. Everyone had performed, and
Right. Has that been an issue in India? Using a porcine model from a religious perspective? Not really. All right. Thank you very much. Well done.
thank you, sir.
Yeah, and what about the, like you nicely mentioned about the differences between the porcine head and the
Yes.
human anatomy. What about the canalicular system? Did you
Ma'am,
try to
only
do
the
a
upper
canalicular
puncta is present in the pig model,
Mhm.
and that is what I'm aware about.
Did you try to intubate it?
Ma'am, what is available in the literature, they've mentioned about the single puncta that is present, but about the lacrimal system, I'll definitely read it up.
Okay. Thank you, Chavi.
Thank you, ma'am. Thank you, everyone.
Now we have Dr. Hitesh talking on orbital mucormycosis radiological findings.
Good afternoon, everyone. My topic is correlation of ocular and radiological findings in rhinoorbital cerebral mucormycosis patients. Rhinoorbital cerebral mucormycosis (ROCM) is an acute, fulminant and lethal opportunistic saprophytic fungi. The exponential rise in the incidence of ROCM is due to certain predisposing factors like diabetic ketoacidosis, solid organ transplantation, prolonged corticosteroid therapy, hemochromatosis, patient with HIV, neutropenia, malnutrition, and hematological malignancies. Normal phagocytic activity in immunocompetent host provides an adequate barrier against the infection. The angioinvasive fungal infection affects the paranasal sinus, presenting as fever, headache, facial pain, nasal discharge, nasal obstruction, and crusting, progressing within hours to days to have orbitofacial and intracranial extension. The patient who has symptoms and signs of ROCM is treated in the treated COVID-19 patients, diabetes mellitus, use of systemic corticosteroids, and mechanical ventilation or oxygen supplementation is considered as a possible ROCM. Probable ROCM is when the clinical symptoms and signs are supported by a diagnostic nasal endoscopy or contrast enhanced MRI or CT findings. It is called proven ROCM when the clinical radiological features are coupled with microbiological confirmation on direct microscopy, culture, histopathology with special stains or molecular diagnostics. Early suspicion, rapid diagnosis, and initiation of treatment determine the prognosis of mucormycosis that can have devastating implications of the patient's survival. This is a retrospective cohort study. 45 positive RT-PCR patients were taken in the study. Histopathologically or microbiologically diagnosed cases of acute ROCM are from the Department of Ophthalmology, Otorhinolaryngology, and Radiology. Relevant clinical and imaging data from the medical records of patients were reviewed and analyzed. Data collection was from April to September 2020. It was analyzed from August to September 2023. Results, this study includes 45 patients with 36 males and 9 females. Out of those, diabetes mellitus was the most commonly associated risk factor seen in 21 patients. These are the rest risk factors. Most common symptoms were headache in 38 patients, followed by fever, facial swelling, and periorbital edema. Common clinical findings were ptosis, proptosis, cranial nerve palsy, total ophthalmoplegia, and central retinal artery occlusion. Maxillary sinus was the most commonly affected sinus observed in 35 patients, followed by parasinusitis was detected in 17. Combination of maxillary ethmoid and sphenoid sinus involvement was noted in 21, maxillary ethmoid in 10, and ethmoid sphenoid in 4 patients. Based on the proposed strategy of ROCM, 14 patients were in stage 2D, followed by 13 patients in stage 1D, stage 3C each, 13 patients in both stage 1D and 3C each. 8 cases were in stage 3D, and extracranial extension noted in 3 patients. Mucormycosis is an opportunistic, potentially devastating angioinvasive fungal infection also known as zygomycosis and phycomycosis of the family Mucorrhizaceae. It is a saprophytic fungi. It grows everywhere. But infection rarely occurs as a patient, only if the patient is immunocompromised. The spores, when they inhale, it germinates and formation of hyphae is seen. As ROCM is the most common presentation in mucormycosis. Depending on the immune status of the individual, most patients in the study has non-specific signs like sinus tenderness, headache, fever, malaise, and signs like ptosis, proptosis, and cranial nerve palsy was observed. These are the pictures of total ophthalmoplegia, orbital cellulitis, and involvement of left orbital apex. Ethmoidal sinus is an important route of infection since mucormycosis invade through this lamina preparation, gain access to the orbit and other contents. These are few CT images showing bilateral maxillary sinus involvement, ethmoid and sphenoid sinus involvement, right lamina preparation involvement, right orbital involvement, frontal sinus involvement, and also brain involvement. Ophthalmoplegia is associated with extraocular muscles and was seen in 13 cases. Cavernous sinus thrombosis was common intracranial manifestation noted in 3 patients. All the patients were started on IV liposomal amphotericin B infusion, followed by they were converted to oral antifungals, posaconazole 300 mg from 6 weeks to 3 months, depending on the clinical and radiological regression. Orbital decompression was performed in 2 patients. This is the post-op picture of a patient having orbital decompression done. It is a retrospective study with a limited number of patients. Few clinical the final conclusion of the study is initiation of empirical and antifungal therapy should be started in the probable stage of the disease, not wait for the microbiological or histopathological confirmation of the diagnosis, which helps in better patient recovery.
Dr. Chaitra will be talking on outcomes of socket reconstruction. Please start.
Good afternoon, everybody. I present to you the outcomes of socket reconstruction with concurrent use of spherical acrylic implants with mucous membrane grafting. Contracted socket, as we all know, is the shrinkage and shortening of all a part of orbital tissues, resulting in decrease in depth of the fornices and the orbital volume, and an inability to sustain a prosthesis. So the net volume loss post enucleation and evisceration will result in the inferior and forward displacement of the intraorbital fat, and a larger prosthesis that is required to fit in will often depress superiorly and pushes against the lower eyelid inferiorly. So all this may lead to the development of post-enucleation socket syndrome, characterized by deepening of the upper eyelid sulcus and variable amounts of upper eyelid dysfunction, ranging from lag of thalmus to severe ptosis, and also stretching of the lower eyelid with inadequate eyelid closure. So the progressive stretching of the inferior fornix of the lower eyelid with the posterior tilt of the fornices or the gravitational effect of the heavier prosthesis will often lead to an ectropion development, which further reduces the fornix available to support the prosthesis, setting up a vicious cycle. So the lower eyelid and sulcus stretch inferiorly will lead to the prosthesis getting to sink. Therefore, larger prosthesis might be required, and this heavier prosthesis in turn places more weight or stretch on the lower eyelid. So an ideal socket reconstruction will require both volume correction and surface augmentation. The deficit volume corrected by an orbital implant restores most of the volume, leaving enough space for the prosthesis to be fit in, and adding tissues in the form of mucous membrane will serve as a replacement for the deficient conjunctiva. So the study was to evaluate the concurrent use of spherical orbital implant with mucous membrane grafting, which was a retrospective observational case series conducted at Kempegowda Institute of Medical Sciences, Bengaluru, over a span of 2 years, which included 30 patients who presented with contracted anophthalmic sockets and post-enucleation socket syndromes. So a socket reconstruction was done in all of them by the usage of a non-spherical PMMA implant, and mucous membrane grafting was done in all of them to both the upper and the lower eyelids, along with fornix forming sutures.
So 27 of them, that is 90% of the patients, had good sockets with adequate furnaces for a well-fitting ocular prosthesis, while 2 of them, that is 6.6% of them, required revision of the furnaces, while 1 of them required a further surface correction. So this was one of the patients with right contracted anophthalmic socket presenting to us, who underwent the concurrent surface volume correction with non-spherical acrylic implant along with mucous membrane grafting, who had a good socket with an adequately fitting prosthesis at 10-week marks. This is another patient with good socket with an adequately fitting prosthesis, and the third patient with good results as well. So we can say that an ideal socket reconstruction will require both surface and volume augmentation for a well-fitting prosthesis. Non-porous spherical acrylic implants are widely used to ensure a good volume correction in contracted sockets. There is no additional advantage and outcomes with using orbital implants made from other materials like silicone or hydroxyapatite or metpore. Among the conventional autografts, the use of mucous membrane grafts is the only one useful in socket reconstruction because of its inherent properties. Thank you.
Would you please explain the procedure just in brief, the surgical procedure, just in brief?
So the
how did you approach the contracted socket for volume and for the surface reconstructions? You are using for that conjunctival part for MMG. In between, how did you go for it?
So
You
the
did include a video,
scar
no?
tissue. Conjunctiva and the scar tissue were incised, ma'am, by horizontal incision, and the spherical, non-spherical, the spherical implant was placed in the scleral bag. Also, the sclera with suturing of the sclera and the conjunctiva. Then the buccal mucosal graft was harvested, and then.
Silicone and PMMA?
No, ma'am. This was all.
But
all
you
the patients
concluded
here,
saying
yeah,
that
there's no
it is
additional advantage with using the.
But whatever you did, all of them were acrylic.
Yes, ma'am.
So this was the last presentation, but we have 2 semi-finalists added from the previous sessions. We have Dr. Pratibha presenting on tier biomarkers in the thyroid eye disease.
Good afternoon. Respected judges, teachers and my dear friends. I am Dr. Pratibha Devi Nivian and I am here to present on tier biomarkers in thyroid eye disease, the first Indian study. Thyroid eye disease is a complex autoimmune disorder. Understanding about the pathogenesis of thyroid eye disease is evolving. We all know that there are development of antibodies against self-antigens in thyroid eye disease, which attacks the orbital tissues, and it can either cause a fatty disease or a fibrotic disease. We know that TED presents from a very mild inactive disease with a mild lid retraction to a very severe debilitating disease with this dysthyroid optic neuropathy and exposure keratopathy. So what do we do now? We treat based on the clinical activity scoring, visa scoring, and grade them according to the UGOGO guidelines. And we treat them with steroids, immunosuppressants, radiotherapy, and few of the targeted therapies which are available. So what is lacking? We treat after the disease is well established in the eye. And most of the audience here and the teachers here would agree that management of an active thyroid eye disease is very challenging. So what could be ideal? Identify the patients who will probably develop an active disease and treat them before they develop a very severe disease would be an ideal thing. So how to find the patients who will develop an active disease? To look for biomarkers. So biomarkers can be seen in various body fluids and tissues, but tears is ideal as it is in direct contact with the eye. The lacrimal glands are also affected, and it is easy to procure tears and it is non-invasive. So with this background, I did some literature search and I found that there were a lot of work done on tear biomarkers in thyroid eye disease. One of an interesting meta-analysis in Biomolecule Journal was the authors had compiled the work done on tear biomarkers, and majority of the authors have found those inflammatory cytokines to be increased in thyroid eye disease. So with this background, and since there were no Indian studies done, I aimed to look for significant markers in tears in thyroid eye disease. It was a small pilot prospective study after ethics clearance. We diagnosed TED based on Gorman and Bartley's criteria. Activity grading was done by visa scoring and severity was done by EGOGO guidelines. The tear samples were collected from 2 tertiary care centers with Schirmer strip. The protocols were followed meticulously in both the centers. The samples were stored in -90-degree refrigerator and the analysis was done in a tertiary care center lab. We collected samples from healthy controls, patients with thyroid eye disease and patients with thyroid disorder but no eye disease. We excluded patients with other systemic and ocular disorders and not willing for the study. We performed multiplex ELISA. Our panel had these inflammatory markers. And in our study, we had 19 patients with thyroid eye disease, 11 patients with thyroid disorder but no eye disease, 13 healthy controls. Among the patients with TED, we had 11 active patients and 8 inactive patients. This was the gross result of our study. We found most of the inflammatory cytokines were elevated in thyroid eye disease compared to healthy controls and the no TED group. However, we noted a statistically significant increase in interleukin 6 and interleukin 10. We also noticed the activity had a strong risk factor for an increase in IOP, and IOP was directly related to this thyroid optic neuropathy. Interestingly, in literature, we did find that antibodies against interleukin 6 receptors were being used to treat patients with active TED. Randomized control trials is being done on that. And we did find that there are so many other targeted therapies for such inflammatory biomarkers. So in future, biomarker detection can give clue to us, as in to say that who could succumb to the disease, and looking for potential markers and treating them with specific antagonists earlier before the visa scoring of 4 could probably help us to avoid high dose of steroids. And to conclude, tear biomarkers can be a promising clue to diagnose patients at risk of developing sight-threatening complications. I would like to acknowledge the people who helped through my journey. Thank you.
It's not from the paper, but related to the paper. They said that there is some launch of biomarkers tier. Is it same? In the conference, there is some launch of tier biomarkers. Is it the same?
Tier biomarkers panel has been in the trade you're telling, ma'am? Yes,
the launching it.
Yeah, that
kit
is
I am
for
asking.
dry eye. So they have launched a panel for dry eye to detect the inflammatory markers for dry eye. We are working with the same lab, and this is in thyroid eye disease.
Good presentation. Just 2 quick questions. Was there any correlation between your findings on the biomarkers and the presence of autoantibodies?
Sir, I actually did not check for autoantibodies in this particular study, sir.
Right.
That would have
And
added
what is
more
your routine
information.
practice? Is it TRAP, TSI, or both?
Sir, actually the thyroid function test T3, free T3, free T4, TSH were done for most of the patients. Many of the endocrinologists still do not advocate or write the antibodies in our setup, and many labs also do not have that antibody. I did not have luxury of doing the test myself.
Right.
I was only able to do this.
So at least don't leave it to the endocrinologist. You ophthalmologists should be ordering these antibodies and order both the antibodies. Second quick question is, where do you plan to take it from here?
Sir, I think this is just a small start, but I think I have a long way to go. My hypothesis is we are treating once the activity scoring is after 4. So if we could revise the thought process and start looking in or following up the patients who even have a mild thyroid eye disease by looking in for markers like this in tears, and if the markers are significantly raised, then even before the visa scoring of 4, we can probably treat them with the specific targets, because this panel gives which one is raised also. That is my hypothesis. I do not know how it would work, but this is my hypothesis.
Great. I think that holds a lot of hope. Thank you very much.
Thank you, sir.
In our second semi-finals is Dr. Marian Polly. She will be talking on outcomes of patients undergoing orbitotomy in cavernous venous malformation. Over to you.
Thank you. My paper is on functional outcome in patients undergoing orbitotomy for cavernous venous malformation. No financial interest. As we know, cavernous hemangioma is a simple venous malformation seen in middle-aged females, and excisional biopsy remains the treatment of choice. However, there is a wide discrepancy in the management as visual impairment can occur due to surgery itself in 2 to 24% of cases. So in this context, we did a study to analyze the functional outcome in patients undergoing surgery for cavernous hemangiomas. It was a retrospective interventional study of 8 years in a tertiary care center. Detailed history of ophthalmic evaluation, imaging, and orbital volume was calculated in all the cases. Surgical approach was determined based on the location of the tumor. Stellar right incision or Burkitt's incision was used. Cryo-assisted tumor removal was done in all the cases. Muscle disinsertion and reinsertion was done in selected cases. Pupil was monitored throughout the surgery. Those patients with a 6 months follow-up were included, and those referred for revision surgery and extracorneal location were excluded. Patient was admitted for 1 day and discharged next day, then followed up at 1 week, 1 month, 6 months, and yearly thereafter. Refraction was done, color vision, visual fields, and OCT was done in patients with subnormal vision. The main outcome measures were changes in visual acuity and refractive error, ophthalmoscopic changes, and complications related to surgery. Coming to results, we had 10 eyes of 10 patients with a mean age of 44 years, with a follow-up of 21.8 months, females outnumbered males. Proptosis was the most common presenting symptom. Color vision was normal in all the patients pre and post-op. Visual fields were also normal in 9 patients, 1 had central scotoma. Coming to ophthalmoscopic features, hyperemic disc and disc edema was present in 2, it was disappeared post-operatively. Chororetinal folds were present in 4, it persisted in the post-op. Serous macular detachment was present in 1, it persisted post-op. Less than 6/18 or equal to was present in 1 patient, which was improved in the post-operative period. All other patients had good vision pre and post-op. Coming to the changes in hypermetropia, hypermetropia was present in 70% with ranging from plus 0.5 diopters to 5 diopters, of which 4 eyes had more than or equal to 2 diopters. In the postoperative period, 5 had persistent hypermetropia, and the average reduction in hypermetropia was 33.6% only. CT scan was done in all the cases. The horizontal dimension ranged from 1.4 to 2.9 millimeters, and the tumor volume from 2.1 to 7.6 ml. Infralateral was the most common location. Lateral orbitotomy alone was done in 7 cases. Lid split was in 1, and combined approach of lateral orbitotomy with the lid split was in 2 cases. Medial rectus disinsertion was done in 1 patient. Coming to the complication, 1 patient had tonic pupil and 1 had late in ophthalmos. This is my index case, pre of hypermetropia, did well with following surgery. So discussion, this is a unique study of 10 patients where dual approach was used in 2 patients of cavernous hemangiomas. None of them had any loss of vision. If you see the visual impairment following excision of cavernous hemangiomas, there is a reduction in visual acuity of 3 to 32% in 3 to 32%, and there is no light perception was reported in 1.2 to 4.2%. It can occur due to CRIO as well as optic nerve ischemia. In our series, all patients are good preoperative vision, and we use dual approach and muscle descent in 1 case. 70% had hypermetropia, only 33.6% reduction in hypermetropia. Harris et al. Noted 75% of preoperative hypermetropia was retained in spite of complete tumor removal. Scleral fibrosis and remodeling with chronic distortion can lead to permanent scleral deformation, and permanent change in axial length could be the reason. 40% had choroidal folds. The choroidal folds persisted even though the height has been reduced. The reported incidence is 14 to 41%. In our series, all were intracorneal masses. And long-standing choroidal folds can lead to RP hypertrophy and later atrophy. Complications, 1 had tonic pupil, but she was asymptomatic. It occurs due to the injury to the short ciliary nerve or ciliary ganglion. Coming to limitations, this was a small sample size. So what this study yards, functional outcome following orbitotomy for cavernous hemangioma remains excellent with careful surgical technique, proper selection of surgical procedure, and careful intraoperative dissection. 2 surgical approaches can be combined if the tumor is at risk for loss of vision. Post-op recovery depends on the preoperative findings. Smaller tumors, small refractive errors, favorable parameters. Large tumors causing globe indentation can lead to persistent choroidal folds. So we propose early surgical intervention in symptomatic intracorneal cavernous venous malformation. Persistence of choroidal folds in the postoperative period needs further research. These are my references. Thank you.
You have 10 patients, na? Yeah. Just a suggestion, a subgroup analysis, you have dimensions of all the tumors, and you have hypermetropia degree also. So somehow you can correlate with the how much is the dimension, how the extent, how much it will be the hypermetropia. Some
Yeah,
group
actually,
analysis it will be a
yeah, actually I
add
have
on.
done tumor time only 5 minutes, no, so that is why I didn't present
Okay.
subgroup analysis.
Yeah, that's
Yeah. Thank you so much.
Yeah, hi. So
No? You're too kind a person. So just first of all, compliments on using the term cavernous venous malformation, because I still am listening and to various talks, including experts who are still calling it cavernous hemangioma. So compliments on that.
Thank you.
You made a statement saying that early intervention for symptomatic lesions. How would you manage an asymptomatic lesion? Number one. Number two, incidental cases, right? We do see them. And what is your opinion regarding conservative management with intralesional sclerotherapy, given the fact that these are malformations? So I'm sorry, I have to ask her tough questions.
Asymptomatic in the sense when the patient just presents with proptosis, vision, fields, color vision, everything must be normal at that point.
I mean asymptomatic is they end up having a CT scan for something else. Have you had patients refer to you with incidental lesions? So those are the asymptomatic ones, no proptosis.
All had proptosis. One patient presented with orbital pain. She didn't realize that she has got proptosis, but all had proptosis. So she was
what would you recommend?
I recommend
to the people in the audience who know less than you.
No, if I personally feel if there is a cavernous hemangioma, it usually slowly growing, and later on it can lead to all the globe deformation, etc., choroidal folds. So if we can intervene early, that's what I feel, so that safe. Because in my series, one patient was keeping the hemangioma for almost 7 years, and he developed choroidal folds, and the fold was persisting even after 1 year of follow-up. So the vision was only 6/12, even at 1 year follow-up. So before that, I think we can intervene. Then sclerotherapy, I don't think, because this is a small venous malformation, so I don't recommend, because it is complete removal. If it is a very posterior, it can cause threaten to the vision, but still sclerotherapy also can cause loss of vision. So if it is surgically amenable, better to remove it surgically, or we can use stereotactic radiation.
Thank you
rather
very
than
much.
sclerotherapy.
Thank you. Great case. Great presentation.
So here we come to the end of the session. I would like to thank all the presenters and the judges for their valuable time. And we hand it over to the next session with the 10 minutes of delay. Dr. Sonal to take over, please.